Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Hello, thank you for joining us for today's webinar on coding respiratory conditions and COVID-19. My name is Molly Casey, and I'm on the marketing team with Axxess. Axxess is a leading home healthcare technology company offering a complete suite of easy-to-use, innovative software solutions, empowering home health, home care, and hospice providers to grow their business while making lives better. Today, you will hear from Nanette Minton. Nanette has been in home care since 1997. She has served in a variety of roles, including clinical, administrative, consulting, education, and agency startup and development. Currently serving as the Senior Clinical Coding Manager for Mac Legacy, Nanette provides day-to-day coding and quality support to the home care and hospice agencies receiving coding services from Mac Legacy. Nanette's experience in the industry gives her a unique perspective and allows her to provide coding and audit knowledge firsthand to clients. Welcome, we're so glad to have you, Nanette. Before we begin, a few housekeeping items. Your phones have been muted, but you may submit questions to Nanette through the chat function. We probably won't have time to take questions at the end, but we will provide those to Nanette and she will follow up with you afterwards. Slides from today's presentation, along with the recording of the webinar, will be available afterwards and will be sent to all who registered via email. We will also have them available on our website and in the Axxess Help Center. Additionally, you can find the slides in the GoToWebinar chat box. There is a link there for handouts, and you're able to download the PDF right from there if you'd like. Okay, Nanette, over to you.
Wonderful. Thank you, Molly. I'm very excited to be able to bring this information to you today. I tend to talk fast, so I'll try to slow down and really provide you with the best information I can. As we get started, it would be an understatement to say that COVID, there's very few people in this world that COVID has not affected in some manner. So our goals and our objectives today are not only to help you understand the ICD-10 classification and how this relates to coding respiratory diseases, but specifically coding those things that occur with COVID-19 related complications, to really interpret who's responsible for applying and assigning those codes, and to develop an understanding of those conventions related to those respiratory conventions. Interestingly enough, after this presentation was already ready, we had another breaking news come out where there was a committee on coding, and we have even new codes coming out related to COVID, and we'll talk about that. And that was even as of September 9th. So still lots of breaking information. One of the things that as we get into this presentation, one of the things that I've talked to some peers about, understanding COVID to begin with, is we really thought it was really a respiratory disease. As we get through this, we talk a little bit more about what COVID does to the body and how to relate that to coding. I almost feel like with every disease process presentation I do, I could put something in there on COVID as to how it relates to that body system. Our focus today, however, is going to be those diseases of the respiratory system. Now, we know our airways are divided into upper and into lower categories. The upper airways include the nasopharynx, the oropharynx, the laryngopharynx, and the larynx. The lower airways begin with the trachea, the bronchial tubes, bronchioles, alveolar ducts, and alveoli. Now, the reason this makes a difference in understanding this is that there's some codes that state related to a lower respiratory infection or an upper respiratory infection. So if you're not clear on understanding which part of that respiratory infection that coding affects, then you're potentially going to have some incorrect codes. We don't always think about the trachea being a lower airway disease. When we think of our our anatomy and physiology in our body, we don't think about the trachea, but it is considered a lower airway. Of course, thinking through our respiratory anatomy, that right lung is larger than the left. The right lung has upper, middle, and lower lobes. The left lung only has upper and lower lobes due to the room needed for the heart. If you kind of look at the picture there on the slide, kind of helps you see the anatomy and understand that. So most respiratory conditions are acceptable primary diagnosis under PDGM. However, as many people as have chronic respiratory conditions, there are actually no respiratory diagnosis in the low comorbidity adjustment table for that. Respiratory 5 category, which includes COPD and asthma, is on the high comorbidity adjustment table when you have interactions from a skin 3, one of those non-pressure chronic ulcers, maybe a lower extremity venous stasis ulcer, or a skin 4, a stage 2 through 4, or an unstageable pressure ulcers. So for those of you who might not be completely familiar with PDGM, you understand there's that primary clinical diagnosis that falls in the clinical grouping. And then you have either no or a low or a high comorbidity grouping. So just to reiterate, there are no category respiratory diagnosis in the low comorbidity group. And the respiratory 5 will interact, which is COPD and asthma, will interact with the skin, a skin 3 or a skin 4 to give you that high comorbidity group. And as Molly said, my contact information will be at the end, and if I don't get to any questions regarding this, I'll be happy to send you some specific examples regarding that. So most of the coding for respiratory diseases comes from Chapter 10, which are diseases of the respiratory system. When you're looking at the coding book, they're coded with a J00 through a J99. However, there's also a new section that has U codes. When ICD-10 came out, there was nothing in the U category, and they actually held this section out for further and future code expansion. You can see on this slide that the J0 through J06 is acute upper respiratory, and then you've got the influenza, and here's where we talked about lower respiratory, upper respiratory infections. And then the J40 through J47, you're looking at chronic respiratory diseases such as COPD and those things. And then lung diseases due to external agents, other necrotic diseases of the pleura, and so on and so forth. I did not mention this earlier, and if it's something that comes up, as I was talking about what falls into a low or high comorbidity grouping for respiratory diseases, actually emphysema, you would think would also qualify to combine with those skin 3 and 4 to get a high comorbidity grouping, but it actually does not. So COPD and asthma do, but emphysema does not, which really doesn't make any sense whatsoever. All right, so when looking at diseases of the respiratory system, J00 through J99, and then we have U07.0. So COPD and asthma. Let's talk a little bit about this before we get into some of the specific things about coding, how to code COVID. So the codes and categories J44 and J45 distinguish between uncomplicated and those in acute exacerbation. Remember, an acute exacerbation is a worsening or a decompensation. I think we forget to think about that as well on that chronic condition. So an acute exacerbation is not equivalent to an infection superimposed on a chronic condition, though an exacerbation may be triggered by an infection. So what does that mean? So let's say when a new patient is referred to home care for an acute exacerbation of COPD, and they're also on an antibiotic. Many times with those acute exacerbations, they'll put the patient on steroids and an antibiotic. Unless the record actually documents that they have some type of infection, you can't assume that they have a lower or upper respiratory infection just because they're on an antibiotic. And just because they have an upper or lower respiratory infection, you can't assume that they have an acute exacerbation. So you have to be very clear in looking at the physician or clinician, nurse practitioner or approved provider documentation to make sure you're clear on understanding that. So that can get confusing. Something else to consider, particularly if you do any hospice coding, is that I will see codes in hospice that COPD is the diagnosis, but they'll use the J44.9 code. In my experience, if that's all that you have, you really need to look at your documentation, because most of the time an end-stage COPD patient is going to have decompensated COPD, and it would be more appropriate to code that J44.1. So remember that J44.1 is not just for an acute exacerbation, but would also be for decompensation. We forget that sometimes. Acute respiratory failure as a principal diagnosis. I actually had a patient I was coding yesterday, and this was one of the diagnoses that was listed on that. And so, I've been in very interesting, I wouldn't say arguments, but disagreements regarding this code. So let's talk about this. So there's acute respiratory failure, and then there's chronic respiratory failure. One of the things that the coding book says is that you are able to code those certainly if they're in the documentation, even in the home care setting. However, best practice would dictate that in most cases, a person with acute respiratory failure is not going to be appropriate for the home setting or continued in the home setting for home care. Potentially that would be the case for hospice patients, but in the home care setting, it's best if you have a patient who's referred that has acute on chronic respiratory failure, that you just code that chronic respiratory failure in the home setting, or if they all is listed as acute respiratory failure, then you're not going to be coding that. And then sometimes you get respiratory failure unspecified, so they don't say whether it's acute or chronic. And if that's the case, then it would be appropriate to go ahead and code and list that. I do want to say that there's some chapter-specific coding guidelines related to poisoning, HIV, and some other sequencing that would take precedence on whether the respiratory failure is coded primary or another condition. And specifically in the coding guidelines, it says respiratory failure may be listed as a secondary diagnosis if it occurs after admission or if it is present on admission but does not meet that definition of a principal diagnosis. So let's say that you have a patient admitted with respiratory failure and some other acute conditions such as an MI, a stroke, or aspiration pneumonia. The principal diagnosis is not going to be the same in every situation. And what you really have to do is look at what is going on with that patient, and it's dependent on the circumstances of the admission. So what is the focus of care? What is the skill most pertinent related to which diagnosis? So let's say both the respiratory failure and the other acute condition are equally responsible for the admission to that hospital, and there's no really chapter specific guidance, then really you could choose either one of these to be applied as primary in this situation. And certainly if there's additional information and you're not clear on which one needs to be primary, then we would want to query the provider for clarification. Let me make a statement here. When, coding is a very complicated process. So when you are querying the provider or querying the physician regarding information, it's very important to be clear on what you're asking, because they will not always understand the depth of the questions you're asking. So it's always a good idea to provide some background and help them understand where you're coming from on that. And I'll be glad to visit with anybody regarding that if there's specific questions on that. So influenza due to certain identified viruses. So you would code only confirmed cases of the flu due to identified influenza viruses and due to other identified influenza viruses. So in this context, confirmation does not require documentation of a positive laboratory test for avian or other novel influenza A. So in other words, it's okay for the coder to code that based on the provider's diagnostic statement. You would not necessarily have to have that lab document proving otherwise. So if the provider records suspected, possible, or probable avian influenza, then the appropriate influenza code due to unidentified influenza virus should be assigned. And then a code from category J09, influenza due to certain identified viruses, should not be assigned, or nor should a code from category J10. That can be confusing related to coding specific flu viruses, because it's not always as clear on how and when, depending on the type of flu that's identified. Let's talk just a second about ventilator-associated pneumonia. This is not something that we see in the home setting very often, but just to be aware, there is an actual code, J95851, for this, and it should be assigned when the provider has documented this specific ventilator-associated pneumonia. An additional code to identify the organism, such as Pseudomonas, etc., should also be assigned after that. You're not going to assign an additional code for the type of pneumonia, because essentially that J95 is a combination code and identifies both pneumonia and the cause of that pneumonia. Now, this J95851 is not going to be assigned when the patient has pneumonia but's on a mechanical ventilator, and that they happen to be on a ventilator and they have pneumonia, unless it's specifically stated ventilator-associated pneumonia. So just something to keep in mind with that. So a patient may be admitted with one type of pneumonia, however, and then subsequently develop that. So in this case, it would be appropriate to code that different code and then add that ventilator-associated pneumonia after that. All right, before we get into talking about specific codes related to COVID, this is another thing that has come out, and they apply to this new section of the ICD-10 coding, and U section would be vaping-related disorders. Unfortunately, particularly in, well, not just in the youth population, but in multiple populations, there has been an increase in vaping. And so for patients presenting with conditions related to vaping, you would assign the code U070, vaping-related disorders, as that principal diagnosis. And so for lung injury related to vaping, assign U070, and then assign any additional codes for other manifestations, such as acute respiratory failure. Again, an acute respiratory failure most likely is resolved in the hospital unless you're talking about a hospice setting, or pneumonitis, which would be J68.0, which is basically another way to say of inflammation of the lungs. The other thing, you might see cough, shortness of breath, and those type of symptom codes. Those are inherent to those vaping-related disorders. And if that definitive diagnosis has been established, you're not going to add those as additional codes. However, if it would be appropriate to code separate diagnosis, so let's say somebody is having GI symptoms evidently have been reported for vaping-related disorders and diarrhea or abdominal pain. That's not something that you would necessarily normally see as an inherent part of that disease process. So you would want to add those to show that. Okay, let's talk about COVID-19. You understand that it is actually a SARS infection, and I remember hearing about that, and you know, back in I've been a nurse for over 20 years, and so back in the day it was always, you know, VRE and MRSA and all of these things, and SARS was something almost you know, you saw in a movie or something. You didn't see currently what was happening with it. So the infection is called COVID-19, but it's caused from the SARS-CoV-2 virus. Kind of like you have AIDS is caused, or HIV is caused from that. AIDS is caused from that HIV virus. Kind of that same concept. So you're going to code only confirmed cases, and this is in the home care setting. I know sometimes when you're looking at the hospitals will say yes, it's okay if they say suspected, that type of thing. They will go ahead from the hospital setting and code those. In the home care setting, we can actually code only confirmed cases. And again, this can be documented by the provider. Or documentation of a positive COVID-19 test result. And so that confirmation for home care or hospice does not require documentation of a positive test result for COVID-19, just that provider documentation, say the history and physical in the list of discharge diagnosis, it says COVID-19. That would be signed by a physician, would be enough to provide that code. U071, that's going to be the code. When I was putting this presentation together, you would be amazed at the all of the electron microscope images that they have now of COVID-19. So if the provider documents suspected, possible, probable, or inconclusive, we are not going to code U071, but we are going to code the signs and symptoms reported instead. Now, this does present a problem for those under PDGM, and so you would have to consider and consult with a physician, because under PDGM, you could not have any of those signs and symptoms as primary. So it might be that the patient has pneumonia, and you would put the pneumonia as primary if you didn't have confirmed COVID or some other respiratory disease. So if COVID-19 meets the definition of principal diagnosis, in other words, this is a primary reason that they're on home care or hospice, and we're going to be doing most of our teaching and training, instruction, or follow-up, maybe therapy because of the weakness related to the COVID infection, whatever might be the case, then U071 is going to be coded primary. Then it's going to be coded separately, additional manifestations that might occur after that. So acute respiratory manifestations of COVID-19. When the reason for the encounter or the admission are those respiratory manifestations of COVID-19, U071, and then we're going to assign those after that. So if a patient has pneumonia, the code that we would use is J12.89, other viral pneumonia. So you would do U071 and then the J12.89. For acute bronchitis, for a patient with the acute bronchitis, and this is the key, confirmed is due to COVID-19. You want to make sure that the bronchitis, that the documentation reflects the bronchitis is related to the COVID-19. You would assign U071, and then J20.8, acute bronchitis due to other specified organisms. Now, let's see, if bronchitis, if it just says bronchitis and not acute bronchitis related to COVID, then you're going to code U071 and J40, which is that bronchitis code that's not specified as acute or chronic. That's not the ideal situation, but we certainly understand sometimes that that's the case, and that might be all the documentation that you have. So if COVID-19 is documented as being associated with a lower respiratory infection or an acute respiratory infection, then you're going to assign the appropriate code. So U071 followed by J22, which would be acute lower respiratory infection. And that should be assigned. Now, if it's documented as being associated with a respiratory infection, like not otherwise specified, in other words, the doctor says you've got COVID and you've got respiratory infection, but he doesn't say acute respiratory or acute lower respiratory, then you would do U071 and J98.8, which is other specified respiratory disorders. Sometimes we would see a patient, and this would be more of a hospice setting, but I wanted to go ahead and mention this because a patient who has COVID then has acute respiratory distress syndrome, then you're going to assign J80 after that to indicate the complication and what's been happening with the patient. As well as if you have acute respiratory failure related to that COVID-19, then you would code that J960, either 01 or whatever was appropriate and documented at the time after that U071. So let's talk about non-respiratory manifestations of COVID-19. It's been really interesting. I'm going to take just a minute to kind of diverge here and talk a little bit about this, because initially when COVID-19 first came out, everybody really thought it was a respiratory infection. Now, I will say that in most cases, that is certainly how it gets into our system, usually through the nasal passages, and does affect the lungs greatly. But as time has gone on and lots of research has been happening, what they're finding out is that it affects, there's really not a system in the body that it doesn't affect. Many strokes, many heart attacks. It's almost as if it's a systemic disease that focuses on the lungs or affects those vessels. A lot of patients, if you have worked in an ICU or acute setting, you've heard the term DIC, disseminated intravascular coagulation, where you have this clotting and bleeding issue. If you have a patient in ICU that has that, it does not bode well for prognosis. So they're finding that, as well as finding that it crosses a blood-brain barrier, and you're finding a lot of COVID-related encephalopathy. So it is an extremely strange disease. We saw, I know most of you probably, there for a while, I felt like I paid attention to the numbers, and then not so much on a daily basis, but over 200,000 deaths in the United States, at least those are the ones that we are aware of. Really this disease, research is saying that it can attack almost anything in the body with devastating consequences. And the ferocity of how it attacks has really been pretty interesting. One of the things too is that you'll have a patient that you'll check their blood, check their ABG or their oxygen saturation, and they're walking around with a startlingly low blood oxygen, and the physicians are saying, the patients are not even appearing to be that short of breath. Normally, you would have a patient with that low, some type of low oxygen saturation would be gasping for breath. So it's been really strange. So when you're infected with a virus, what happens is those virus-laden droplets are inhaled, however the exposure occurs, and that novel coronavirus, the SARS-CoV-2, enters the nose and throat. So it goes into the lining of the nose. And then one of the things that the lining of the nose, there's cells that are rich in a receptor, and it's the ACE2 receptor. So what happens, this is also, there's been some controversy over patients who take some type of ACE inhibitor drugs, has that, or could that potentially affect it? And currently the research is saying that that does not. There doesn't need to be a big panic for those people who are on ACE inhibitors as being a higher risk. So what happens is throughout the body, the presence of those ACE2, which normally helps regulate blood pressure, marks those tissues vulnerable to infection. And then that virus requires a receptor to enter. So once it hijacks the cell's machinery, it copies. And of course, that's how the virus does. It goes mad, making multiple replications of its cells. Those cells invade new cells, which and the process continues. So as the virus multiplies, an infected person may shed copious amounts of it, especially during the first week or so. And really, that's part of the problem, is those symptoms may be absent at this point. So you've got this rapidly multiplying viral infection wreaking havoc on your body, and you may not even have any symptoms. Or the virus's new victim can have the fever, dry cough, sore throat, loss of smell, taste, body aches, the things that we have seen over and over to prove as part of that. So, and here's where it gets complicated. So if the immune system doesn't beat back SARS-CoV-2 during the initial phase, the virus will then march down the windpipe, attack the lungs, where it can turn deadly. So these thinner, distant branches of the lungs respiratory tree that have the tiny alveoli, those air sacs, are each lined by those cells that have a lot of those ACE2 inhibitors. And so normally, oxygen crosses the alveoli into the capillaries. You've got the blood vessels. So the immune system is really at war with this invader. And so as things heat up, those white blood cells release inflammatory molecules called chemokines. And so you've got that cytokine storm, and that really summon more immune cells, and they target that, kill the virus. So as the virus is killed, you've got fluid and dead cells and infected material behind. And so it is that's kind of the underlying pathology of the pneumonia of COVID, because it corresponds with the symptoms, the coughing, fever, shallow, rapid respiration. And so, what happens too, then as that progresses, they may progress to that acute respiratory distress syndrome, or then the alveoli became full of fluid and things, and that attack on the lungs makes it very difficult. So we know it affects the lungs, and really scientists are really just beginning to probe and understand all of the other organs and how it affects. They say it affects the brain, the eyes, the nose, the heart, blood vessels, liver, kidney, and intestines. And so one of the things besides that, when that cytokine storm happens, is the immune cells start to attack those healthy tissues. You've got leaking blood vessels, blood pressure drops, clots, and organ failure. So again, there's so many things that have been affected or affected that. The more they look at the disease as well, the more likely it is that blood clots are really a major player in the disease, in the severity of the disease, as well as the mortality. So they've really been shocked by the fact that there's not some people that you would think would be more high risk. It's turning out that it may be other people. You know, they've said diabetes and high blood pressure patients have, with potential vessel damage, have a whole lot more of a problem. And about, maybe a third of hospitalized patients had chronic lung disease, but nearly as many of those hospitalized with COVID had diabetes, and about half had high blood pressure. So when I say to you it's a systemic disease that affects the lungs, it kind of helps make a little more sense about that. Just briefly, as well as that cytokine storm affecting the lungs and the vessels, it can also affect the brain to cause some type of meningitis or encephalitis, and affect, the neurological system of that. I wanted to take just a second to talk about treatments as well. There's a lot of misinformation and research out there regarding some of the treatments for COVID. There was a really big thing about taking the anti-malarial drugs, the chloroquine or hydrochloroquine. And one of the things that, physicians began prescribing this along with an antibiotic, and it did appear to help some, but the volume of what they were prescribing and kind of the lack of research and regulation or trials that weren't really clear and randomized weren't taking into effect that a lot of those anti-malarial drugs have huge side effects with heart rhythm problems. And so although the side effect can be rare with the higher doses and the amount of people taking it, it was a huge factor in looking at all of that and why there's been so much controversy over the use of that drug. They've even talked about using ivermectin, which is an anti-parasitic parasitic drug, something that they're looking at on that. Interestingly, that's something that has been used for scabies in other countries. The other thing is looking at drugs used for GERD or reflux may have play a potential role in all of that. So obviously we're way early in any of the research of what's really assisting and helping the patients. At first, they would put everybody on a ventilator, and then they found that maybe that wasn't always the best. So they're looking at that research and found that very, very interesting. So thank you for letting me diverge on that. I just wanted to give more information as we're talking about respiratory conditions. And as we, in the home care setting, and these patients are either not admitted to the hospital or are testing positive, but not sick enough to be in the hospital, we're going to be caring for them in the home care setting, and we need to know what to look for in those potentials. Okay, so let's say you have a patient, and this may very well be the case. They're referred to you, and you have an asymptomatic individual with actual or suspected exposure to COVID that you would want to be sure and add this code to their coding, Z2828. It's certainly not going to be primary. You're going to drop that down the list, and you're going to have that's contact with and suspected exposure to other viral communicable diseases. For the symptomatic individuals with actual or suspected exposure to COVID-19, but the infection has been ruled out or tests are inconclusive, you're also going to use Z2828. We've all heard multiple people that have been exposed or potential exposure, and their first, it's based on what type of test they had, when they had it tested, was there enough viral load to be picked up on it. So there's lots of factors involved in that. So what they originally came out and said, before I go over the newest guidance on this, is screening for COVID-19. It says, during the COVID-19 pandemic, a screening code is generally not appropriate. For encounters for COVID testing, including preoperative testing, code as exposure to COVID-19, and they're going to update that guidance with new information. So we have that. This is not in your presentation, so if you do not want to jot this down, and we don't always use screening and exposure necessarily in the home care setting, but they've also given us guidance for personal history of. So that would certainly be something that could be potentially a part of something that could affect the plan of care. We would want to make sure was coded. So on September 9th, there are actually 3 new COVID-19 codes that are proposed for implementation in January, so January 2021. These are not effective yet, and so they're undergoing that whole process. So for screening, it's going to be Z11.52, encounter for screening for COVID-19. For exposure, it's going to be that Z20.822, which is that suspected exposure. And then for personal history, there is actually a code, Z86.16, personal history of COVID-19. Now remember, Medicare uses a lot of these things for research. So I do think just from a clinical standpoint, it's important to make sure that our coding is accurate. Down the road, we don't know what later manifestations we're going to see as a result of someone who's recovered from this disease process. So these are potential codes. They will probably be released. These are the proposal ones, and so we'll get complete further guidance. So these are proposed for January 2021 implementation. All right. We've talked a little bit about this. For a patient that has signs and symptoms without COVID, you would code those, but you would have to coordinate with the provider or determine an alternate diagnosis if it was a Medicare patient under PDGM. So what about an asymptomatic individual who tests positive? Well, you were going to go ahead and code that U071. That would be the code that you would use for that. Now, if they're referred to home care and they're positive for COVID, you would look at the focus of care. Certainly, if they're not symptomatic, that's probably not the reason for home care, but you would want to certainly list it in those diagnoses as the potential to affect that plan of care. And again, until these codes are approved for January 2021, you would, if you know a patient has a history of COVID, then you're going to assign that Z86.19, personal history of other infectious and parasitic diseases. I love this slide here. So it really talks about the body systems and how all of that is affected, respiratory, neurological, cardiovascular, and it just gives you really an overall view of what's happening with that disease process, just as we had talked about earlier. Now, in some of the series of presentations that I've been doing lately, one of the things, because we have not been able to travel because of COVID, I tried to make these a little less boring and to just throw some tidbits in there on destination success. How are we being successful with ICD-10 coding? And so I thought it was very interesting that there were some sites out there that actually say, hey, if you have lung disease, how do you go on vacation? So it's important for obviously those who are ill or have chronic diseases to go on vacation too. And so the research said, obviously, avoid cities with dirty, polluted air, be careful about high altitudes, and be aware that air travel advance notice is required to make arrangements for oxygen needs. Personally, I have a mother with COPD who is going to turn 80 in a couple of years, and we're really looking at taking her on a great vacation, and we have eliminated that airline option. It just will not work for her with her oxygen. So I understand that struggle for sure, to think through that. So towards the end here, I've got a couple of other places that, specific places that they've said are safe or clean lung disease places. So when we visited a little bit earlier, we talked a little bit about COPD, but I want to come back to this actual definition. You know, COPD is actually a generic term that represents any unspecified chronic obstructive lung disease. It is an irreversible airway obstruction, and it when you think about COPD, you think of chronic bronchitis, chronic asthma, or emphysema. Now, the etiology of COPD can be, there's actually 3 different etiologies. Most of the time we think about that as being an environmental cause. Somebody has been smoking for 30 years, or they have been exposed to some type of occupational hazard, dust, chemicals. But there's also a genetic cause. The alpha-1 antitrypsin deficiency can be a genetic cause of COPD. Cocaine, methadone, or heroin as a chronic IV drug use can also be something as a cause of that. So emphysema and the pathophysiology of emphysema, how that differs from COPD is that emphysema is a permanent enlargement of air spaces that are distal to those terminal bronchioles. It leads to a dramatic decline in the alveolar surface that are available for gas exchange. There's a loss of that surface area, which limits airflow. And then you've got this decrease in the elastic recoils and certainly the airway narrowing. If you've been in home care long enough, you can kind of determine those emphysema patients a little bit differently than the COPD, the chronic COPDers, because the emphysema would be a little more of, when you think of that, typically very barrel-chested type of body structure. One of the things to consider too, I always like to throw this out there, we don't always think about nutrition and how nutrition affects COPD patients, because by the time they get to that level, usually even taking a little bit of food, it's hard on their appetite and they're worn out and short of breath even from eating. The recommendation is, if you ever wondered why someone with COPD drinks a lot of coffee, is because there's actually a bronchodilator effect in those patients. And I guess unknowingly, they know that helps them breathe a little better, and so they'll do that. There's also research out there that high fat foods help with breathing distress, whereas, you know, the higher carbohydrates may not lend to that breathing assistance as much. So the nurse and me felt like I needed to throw that out there for you today. All right, so we've got COPD. J44.0 is the code you would use when you have COPD with acute lower respiratory infection. J44.1 with acute exacerbation or decompensation. And then you've got COPD unspecified with that J44.9. So let's go over just a couple of quick scenarios. So if the record documents emphysema with COPD, J43 should be coded. If the record documents emphysema with chronic bronchitis, then J44 should be coded. So COPD is not necessarily with chronic, synonymous with chronic bronchitis. So be aware of that in your documentation. Many times I've coded a chart that had COPD, and then the new charting or documentation has emphysema, and so you end up having to update that coding with the most updated code. All right, so for those of you who would want to do some traveling with lung disease, you've got Santa Fe, New Mexico as a great option. So that's kind of interesting, and really that they say that the air quality, because of the 1.5 million acres of national forest, air quality is really a high priority out there. And it's interesting that it's one of the only 20 U.S. cities, I can't talk today. It's only 20 of one of U.S. cities the American Lung Association reports as having consistently safe ozone layers and ozone levels. So thought that was really good. All right, we have a patient admitted with chronic bronchitis and emphysema. He was a longtime smoker, but quit 1 year ago. And then he's got continuous oxygen ordered via nasal cannula. Now, I do realize that this is a very small segment of codes, and that most likely this patient would have 2 or 3 paragraphs of a history with multiple other diagnoses. But for the sake of today's education, I wanted to keep it a little simpler. So J44.9 is what you would code. Remember that in this case, the patient has emphysema, but the documentation also indicated chronic bronchitis. So if that's the case, we would code that J44.9. The patient is dependent upon oxygen, so we're going to add the Z99.81. And then history of tobacco dependence would be coded with the Z87.891. All right, patient admitted with emphysema and COPD. Current documentation indicates that the patient is a cigarette smoker and then has a history of recurrent pneumonia. How would we code this scenario? And I just wanted to be sure and reiterate the differences between how you code COPD and emphysema, because it's when I'm doing coding audits, it's one of the things that I find a great amount of errors on. So J43.9, you would code the emphysema. You would also code nicotine dependence, cigarettes, uncomplicated. And the reason you would code that is because the documentation lists that the patient is currently a cigarette smoker. And then you're going to list the personal history of pneumonia as Z8701. So look at this other beautiful destination. Honolulu, Hawaii is a beneficial part of the planet's high atmosphere, it says. So, you know, one of the things about Hawaii is they said that there are particles that result from burning coal in that area that can travel great distances, that few are very likely to reach this location in Honolulu, which is actually 2,000 miles off the mainland in North America. So I thought that was pretty interesting. So a patient is admitted with influenza that resulted in bacterial pneumonia. The culture is positive for Staphylococcus, and the nurse is going to be observing, assessing, and instructing on recovery of the pneumonia as the patient continues on oral antibiotics. The patient is on oxygen as needed, and the focus of care is the pneumonia. So how are we going to code that? In this particular case, we're actually going to code the J11.0, the flu due to an unidentified virus with specified pneumonia, and the pneumonia due to Staphylococcus. So that's a combination code that combines the pneumonia with the agent causing that. Now, our example stated that the focus of care would be the pneumonia. Why did we code the flu first? And that's just one of those coding rules that you have to understand, that it'll say to code first the cause of that. So that is why that's coded first. And of course, we're going to list our oxygen dependence. So we have a patient that was admitted for acute exacerbation of COPD. The patient also has moderate persistent asthma. How would we code this? We would code the COPD J44.1 because we have an acute exacerbation documented. And then we're going to add the J45.40 with the moderate persistent asthma listed as uncomplicated. Now, in the coding world, if you have COPD and then you also have asthma listed, but it doesn't state the type of asthma, just asthma not otherwise specified, then you're not able to code that. You can only code the asthma with COPD if the specific type is identified. Here's another beautiful lung-friendly destination would be Port St. Lucia, Florida. It scores in the top 5 American cities on that 2012 State of Air report. So kind of interesting, those of you who might be from Florida or in Florida. Okay, got a couple of more coding examples here as we begin to wrap things up. Patient has been diagnosed with emphysema, COPD, and acute bronchitis. So how are we going to code this? We're going to code the emphysema and the acute bronchitis. Again, remember, it did not say chronic obstructive disease. It just said COPD and emphysema. So that's why we're coding it in this manner. In our last example here, the patient is admitted with an exacerbated COPD and lobar pneumonia. The patient has comorbid conditions of hypertension, chronic systolic heart failure, obstructive sleep apnea. Our focus of care is going to be the COPD. How would we code this patient? You've got COPD with acute exacerbation because we have a documented acute exacerbation. Remember, I said it's not necessarily synonymous with that, but in this case, the patient did have both. The patient also has lobar pneumonia. So when you have a patient with pneumonia and with COPD, you can assume that that pneumonia and COPD have some type of relationship, and you can add the code. The only time you wouldn't code a pneumonia related to COPD would be such a case if you had an aspiration pneumonia or some other, like we talked about, the ventilator-associated pneumonia or something not associated with a lung disease for another example, as another cause. And so then we've got the J44.0, COPD with acute lower respiratory infection, and then you've got the lobar pneumonia. Then you've got hypertensive heart disease with heart failure, the chronic systolic heart failure, and obstructive sleep apnea. So some things to remember. It's really important, and in the coding guidelines, you always, for lung disease and heart disease for that matter, want to code tobacco use or exposure. That is a required coding guideline. Accurate COPD coding really depends on that thorough documentation. And remember, you can't code something just because the nurse said or the patient said. You have to have that physician verification. Even if it's I'm calling the office and getting a verbal order for that documentation that the patient has this particular diagnosis. In most respiratory codes are valid as primary under PDGM, and then a very few, but there are a couple that are going to contribute to that comorbid adjustment. And we talked about that earlier. Here are the references for my slide presentation. And I hope that you had the opportunity to enjoy and learn a little bit yourself about COVID-19. And I hope that was helpful for you. I thank you for attending, and I hope you have a great day. I think Molly's going to finish up for us here.
Nanette, thank you so much for sharing all this great information with us today. And for all of you attending, don't forget, we will email you a link to the slides as well as a recording of this webinar if you'd like to share with anyone on your team. And we will also get them posted on our website, axxess.com as well. Thank you all for joining us today and for joining us with Nanette. We're very appreciative of all of her willingness to share everything she knows, which was quite a bit. So we're grateful for that. Thank you. And thank you all for joining us as we deliver on our mission to empower healthcare organizations and professionals with the world's best technology solutions. Have a wonderful afternoon. Thanks so much.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on software advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.